Great. So we are going to spend the next 13 minutes with some of questions. So listen, thank you so much for those great lectures. For the audience and for the parents and family, these lectures are very helpful and are going to provide a lot of information, not only today, but actually in the future, since this is going to be available in the website of the Acute Flux in My Life, this working group. I am a clinician. I see these patients in the intensive care unit and the emergency department when they come. And I deal with the parents and families since day one. And obviously, they are very eager to a very quick recovery. And I frequently give parents and families the conservative approach. And I say, well, we will pass the acute phase and we'll try to bring everything under control. But obviously, the question about surgical transfer will emerge very soon. I guarantee I heard that in 2018 all the time, is when to bring you to the discussion table. And my question for you is, you emphasize in your lectures today that as early as possible, it is better. However, I also see the patients that recover very quickly, over 1 month, 2 months, and even at 12 months, patients recover even without any meaningful intervention. So I am a little bit cautious dealing with my patients, and I like to do a very thorough assessment, not only clinical with the physical assessment, but also using other techniques like MRI after the acute phase and nerve conduction studies and EMG. So tell me, I will start with Dan and later with Amy and later with Alan. So what is your approach when you are interacting with the neurology group and the clinician group about bringing other approaches to basically do a very good assessment before committing these patients to a surgical intervention early on, let's say 7 months or 9 months? Because in my view, it's obviously the earliest that we can bring these patients to the operating room. So Dan?
Yeah, so I think partly to Alan's point is we're looking at an earlier plateau overall than we initially had assumed. But I think a lot of it has to do, as he stated, as to what's the trajectory of that individual patient. So true, at 6 months, maybe they've plateaued, but maybe they're making changes. So I think it's really important to get to those patients, at least, you know, in this sort of COVID world where it's really difficult to see patients, at least a telehealth session with somebody at around 2 months. Because 2 months is a really meaningful time period. 2 months is where neuropraxia has already resolved or is about to resolve, right? And then you follow them monthly to see what's their trajectory. If they keep improving, then you're obviously going to wait until they plateau. If you see them at 9 months, you have to make a decision on the fly without any history of what that patient was like beforehand. And I imagine that I'm not alone in feeling that way.
Yeah.
So that's one. And then, sorry, Amy, go ahead.
No, I thought you were done. I was ready to roll in. You keep going.
Yeah. So I think the other question is what diagnostic studies? I think you alluded to that. We tend to be fairly minimalist. I think Alan and I have had these conversations in the past. We do not get EMGs or nerve conduction studies to determine if a muscle is not working or if a nerve is not working. We get it only to look for donors. So what happens is, as Amy said, you can have an 80% decline in the axon count of a nerve, and clinically it's not evident. So we actually will get an EMG and nerve conduction studies which are more quantifiable, and in the setting of can we harvest, for example, if I want to do an Oberlin, I'll get an ulnar nerve EMG and nerve conduction study to see if the ulnar nerve is normal. And if it's not normal, I will not take from it, right? So that's our criteria. But I won't do it to it. I know that the biceps isn't working. I don't need a test to tell me that it isn't working.
Yeah, so I would echo, but it comes hard when I think about whether I'm going to use an EMG and nerve conduction study in children, because I think it's very difficult, and I applaud the neurodiastaticians who are obtaining them. And so I really go by my intraoperative stimulation. I look at the exam. If they have nothing on exam, they're not a candidate unless I'm going in for pain. And I'm very clear of just defining what I would be doing. But if it's from a motion standpoint, I test it on exam, I document it, and for the lower extremity, all we have is the MRC grading, right? So that's what I'm using. And then intraoperatively, if I can find redundancy on 0.5 milliamps on that handheld device, then I'll take it. However, with these children, they have so little options sometimes that I'm like, well, it's not perfect, but if I do nothing, I'll get nothing. And so that comes down to, am I operating too soon? Well, I haven't had the luxury of really operating too soon because it's just been harder to get to me. And I don't, prior to coming to Columbus, I didn't have a big referral rehab center to even help see children be filtered in early. So I'm not seeing them in the ICU and things of that nature. However, what I have found, and what even, the child I even saw today, it's really important to say, well, when's the last time you saw a change? And was it over the last week? Was it over the last month? And most of the time they can tell you, well, I noticed the shoulder started moving again 2 weeks ago. I mean, these parents are on top of when their changes are seeing. So for me, like, I canceled 2 surgeries, and it was, I think, outlandish on the Facebook page because Dr. Moore sent me home. But because they were recovering movement that I didn't see before, and then what if I could use a donor differently? So it became, my algorithm changed. And so I am seeing them serially. So ideally I would see them by 3 months. I don't think I would intervene. No, I wouldn't intervene before 3 months, but it would help me have, and telehealth, looking about the telemed has been amazing because I've been seeing my patients for the first time in years, because it's hard to ask somebody to return to us. So I will be quiet, but that's my thoughts. Passing it on, Dr. Belsberg.
So obviously, unfortunately, the 3 of us are always going to agree on everything. But it's a really good question, Carlos. And, I'm privileged to work here with you and Christina. So we're all at Hopkins and at Kennedy Krieger together. So I get to see these kids early because, we're in the same place. There's no question that when you listen to Amy and Dan and myself, the surgeons are saying we need to see these children early. We don't want to have the referral 10 months, a year and a half. We want to see the kids as early as we possibly can. We're happy to see them at 1 month. Not that we're going to operate at that point, but we want to meet the family and the child and get to know them. And right now, the state of the art is simply experience. It's wisdom and experience. Unfortunately, it's not hard science. We don't have enough data. So experienced surgeons like Amy, like Dan, like myself, we're seeing the patients and making individual decisions based on that particular child's progression. And that's what you're hearing from Amy and Dan. You have to individualize it and see how each child is progressing or not. Now, there's no question that we are moving earlier. What was published was 9 months, and you already heard that both Amy and Dan, and certainly myself, we're willing to operate earlier than 9 months. We know that that's already getting late. So it is changing. As far as the investigations, what adjuvant studies, we simply don't have enough data to know what are the best studies, if any of them. So what we're doing is we're gathering data. We're learning as we go. We're trying to be as critical as we can in gathering data on EMGs, on muscle biopsies, nerve biopsies, MRIs, and hopefully as we gather data and as the families who are being tremendously wonderful at participating in this data gathering, as we gather more data, I suspect we will know within 1 or 2 sessions of AFM really whether adjuvant tests like EMGs and MRIs are going to be helpful or not. Unclear right now.
I do have actually my dear colleague Christina, who is probably one of the best people to tell us about the outcome measure of these patients. So I think that it's a conversation between the surgeon, the clinicians, and the rehabilitation specialist is critical. Christina, what is your opinion about this approach?
Well, I think that, early evaluation and serial follow-up is essential for, it doesn't matter what specialty you're of, as long as it's done in a pragmatic way. And I do have questions about, what are the side effects, the risks of early transfers, of cutting nerves. We're talking about a degenerative, a disease that takes away neurologic function, and you're coming with another damage to the nervous system. We're also talking about, the role of rehabilitation, and we've heard your colleagues, the spine surgeons, talking about how we can put them all together. And I didn't hear much about it in your talks. And I think Dr. Bovey has a very important questions there about the potential post-polio concerns, theoretical concerns on this nerve transplant. So,
So again, it's nerve transfer, not nerve transplant. Remember, and as the post-polio goes, so Ahmed Hoke, who's Carlos, as you know, Ahmed has looked at post-polio syndrome a fair amount, as has Vinay Chaudhry. We've not seen post-polio syndrome been described, at least from what I've seen in the literature, so far on any of the nerve transfers with AFM. We've not seen it described on any of the nerve transfers for transverse myelitis, which people have been doing actually longer than for AFM. And we've been looking for that. I know Ahmed's been looking for it, and I've been looking for it. So while it is certainly a theoretical concern, all we know at present is nobody has reported it as yet.
Yeah, that's what I was going to say. I think that we hear about the concerns of the patients. I hear about the scar is wide, there's swelling. I feel like if we were seeing this post-polio syndrome that we're afraid of, I think we would have heard about it now that we've had the numbers that we've had. But again, I'm ignorant to that aspect of it. But I think, though, the risk of waiting is that we're not going to get any function back, and this is what you're going to get.
Yeah, sorry,
there is
Carlos,
a question. There is a question that I believe is coming from one of our audience. Is let's say that we wait 4 or 5 years, and there are people already at that stage that are very anxious to see how they are able to recover. Is there any perspective? I know that you talk for our specific AFM patient, but what about patients that already experienced this in 2012, in 2014? Is there any other surgical approach, at least, that you may think about?
Absolutely. So you've already heard about tendon transfers. So we had some great presentation already on tendon transfers. Those can be done anytime. They can be 20 years after an injury. There's something that I think in the chat room we talked about, a free muscle transfer. For example, if your bicep muscle has been denervated for over 2 years, that muscle's not going to come back. But we can take a fresh piece of muscle from the leg, put it up into the arm, hook up a blood supply, and then do a nerve transfer to reinnervate that muscle and get an elbow to bend. So that particular muscle transfer or free muscle transfer can also be done anytime after an injury. It's not time dependent. At the end of the day, what you need to do as a patient is find a group, and it's usually, as it's already been said multiple times today, it's usually a multidisciplinary group who can provide more than one, tool out of the tool belt and really bring a lot of modern medicine to bear. There are many different things that most surgeons, or at least experienced groups of surgeons, can offer even years later.
Dan, what is your opinion about the muscle transplant?
So free muscle transfers are a great idea. And again, you don't have a timeline. The downside is that, and what makes it difficult is you still have to find a viable muscle, and you have to find a viable nerve to plug it into. So you need those two things. A lot of kids with AFM will not have a muscle in the lower extremity that they can spare, nor will they have anything locally that we can do. Not even, a free muscle is a big operation. If you can take a muscle transfer locally, that's always the better option. So always try to go with the least invasive, most local, right? Think globally, act locally, something like that, right?
Yeah,
So
I agree
yeah,
with
go ahead.
that. So I do a lot of free functional muscle transfers for nerve injuries and have done it for the lower extremity. And that's most of the patients that from these earlier cohorts that I don't have a good option for, because they usually don't have the donor. So they don't have the donor nerve, or both legs are involved and we don't have a muscle I can transfer. And or if they're completely flaccid on one leg and I can restore one muscle group, is that really worth the 5 days in an operation and that 5 days in the hospital stay, 6 months? Like that's the conversations I'm having with patients from these earlier cohorts is, I can do it, but is it worth it? And I don't know yet. I haven't been compelled to do it yet on these globally affected limbs.
Yeah, and I think the other issue is that COVID really is a concern here, in the sense that because none of these interventions are time dependent, as Alan said, there's no reason to really push it now.
Yeah, no.
Right? I think that we want to make sure that, our job is also to think about the patient globally. And that means make sure that their parents are well and they're able to take care of these children. And so I think placing the family at unnecessary risk to do something that can be done at any time, I think is a concern right now. And I think when you have an open timeline where you have with muscle transfers, free muscle transfers, or local muscle transfers or tendon transfers, these things can wait. And there's no reason to push it in my mind right now. I don't know how Alan and Amy feel about that.
I agree with Dan. I think that's a tremendous point that you're making. I couldn't agree with you more. The one thing I would say about that, and it goes back to what Christina said a little earlier, and I certainly know that Amy and Dan agree with me on this. Rehab, physical medicine, so occupational therapy, physical therapy, and so on are absolutely integral with what we do as nerve surgeons. Now, we can delay tendon transfers, we can delay a free muscle transfer, and I agree with you, Dan, this is not the time with COVID to be doing it, but we do need to know that the occupational or physical therapy people are still working with the family to maintain the integrity of the joints, the ligaments, and so on, so that when we do a delayed repair, be it months or years later, as much as possible, we've preserved the ligaments, the joints, all of the different musculoskeletal structures. And that relies on occupational and physical therapy ongoing. And that could be done by the parents, but we usually want to have one of the therapists or rehab physicians supervising that.
Great. So unfortunately, we are a little bit with a limitation in time, but once again, thank you so much for your help, your effort. I have a special request is please stay connected with your colleagues and clinical colleagues and rehabilitation colleagues in the AFM group. I think that we need you. We need to talk with you. And actually, I know that there are other colleagues in surgery, Mitch in California, colleagues in Texas, other surgeons that are involved in the AFM working group. But it's extremely important that you stay with us and collaborate and coordinate the effort for facilitating communication and helping these families and patients with acute flaccid myelitis. And again, thank you so much. We are going to move now to the stage because we are going to listen parents. And again, thank you so much and stay safe.
Yeah,
Thank you, Carlos.
Thank you.
Alan, Christina, Amy.
Nice seeing you guys.